Oh my
Good
God.
afternoon, everyone. My name is Dr. Carlos Perez, welcoming you to Nova Southeastern University. This afternoon, we are featuring Dr. David Reitman. And Dr. Reitman, go ahead and introduce yourself a little bit. I'm going to turn off my camera.
Hi there, Dr. David Reitman. I'm a professor at Nova Southeastern University College of Psychology. I'm going to walk you through some information about ADHD treatment and the treatment of disruptive behavior disorders today. And hopefully we'll have an opportunity for you all to ask questions or make commentary. And if we can arrange the technology in such a way as I can respond in close to real time, I hope we can have something of a conversation. So about 2/3 of this is going to be information that would be generally applicable regardless of what the circumstances were. And then the last third is going to be talking a little bit more about what's happening with COVID and how what we've talked about might apply to that. And I'm sharing some resources with you from people that I have a lot of respect for that I think will be beneficial to you, and things that you can share if you're a therapist with clients, and if you're a parent, things that you can use yourself. So Carlos, if we're ready, I guess we'll just go ahead. With your permission.
Proceed.
Okay, we will proceed. What I'm going to start out by talking about is that most psychologists and people that are familiar with what psychologists do are very concerned about diagnosis, and there are a lot of reasons to be concerned about diagnosis. Sometimes if you don't have the proper diagnosis, you can't get care, you can't get care paid for. We're all well aware of that. But we're not always aware of some of the downsides of that. And I'm not really talking about labeling, although many people are concerned about that. That's not really my primary concern. The diagnostic approach, when a medical model is taken, which is what the DSM was established by psychiatrists who are physicians by training, and what that leads to, in terms of the logic model for prescribing treatment, is that your treatment is based on diagnosis, or in Latin they call that indicatio morbis, and so treatment should follow from your diagnosis. And of course, a lot of treatments, including psychological treatments, have been based around that logic, because in effect, psychology has adopted a medical model simply by virtue of adopting a sort of diagnostic approach. So there are treatments for ADHD, conduct disorder, anxiety, depression. You take your pick of the names, but we have treatments for every condition, right? But if you take a functional approach, your approach tends to be less focused on diagnosis and more focused on problems. And I guess if you come away with nothing else at the end of this day, the end of this hour, I would hope that you would begin to give some thought to the idea of framing your treatment approach or your problem-solving approach around problems as opposed to diagnoses. So if we accept that the world as it is based around treatments that are designed for a particular diagnostic category, one of the benefits of that is we can learn something then about what sorts of treatments tend to be effective for, generally speaking, what kind of clinical presentation. And there are some things that we know don't meaningfully change outcomes for kids with disruptive behavior disorders. And in the disruptive behavior disorders, if you don't know what those are, ADHD, obsessive compulsive, ADHD, ODD, oppositional defiant disorder, and conduct disorder, there are things that we know don't have a great deal of positive clinical impact. And among those things are nutritional modifications, kind of over-the-counter herbal remedies. Even if they call them homeopathic, that doesn't automatically make them effective. Play therapy, while having a position in our clinical approach for conduct problems, the research is not strong supporting them. For other types of conditions, trauma and things like that, there's a separate literature that applies to that. But when it comes to conduct problems, there's not a great deal of evidence to support play therapy in its pure form. Right now, there are some forms of behavior management training that incorporate elements of play therapy, like parent-child interaction therapy, but I wouldn't consider them to be play therapy per se. There are other things that have actually not only been shown not to work, but potentially harmful, and holding therapies and things of that nature, where adult human beings are laying on top of children to simulate the birth trauma. Those types of things, obviously, in some extreme cases, have actually caused death. So we want to steer away from those kinds of things. And again, biofeedback, while having some research support in some other domains, as far as a treatment for the kinds of problems that occur for children with disruptive behavior disorders, the data aren't strong there. So my advice to parents and to practitioners is stay away from those things, right? Stay away from things that we either have strong evidence that it doesn't work, or strong suspicions. Steer clear of those. And why? Because we have things that do. And so what kinds of things are helpful? The kinds of things that are helpful, and we have a pretty strong evidence base for, are behavior management training. I call it parent behavior management training because I dislike the term parent training. I don't believe we are training parents. I think that's the kind of height of hubris. Parenting is complex. There are a lot of elements to it. Most approaches to helping parents with children with behavioral issues are really focused primarily on discipline practices. And so where we kind of limit the definition to that, there's pretty strong evidence that we can help parents to learn to improve their discipline practices and other things as well. But for the moment, let's stick to that. As far as academic problems are concerned, classroom behavior support, behavior management, accommodations, those types of things are clearly established in terms of their efficacy. For social behavior, that's a little bit more controversial. Group treatments that occur in clinic where there's no effort to generalize the training outside of the peer group or the group therapy situation are not particularly effective. If there are efforts to try to connect what's happening in these peer socialization groups to the home and to the school, the benefits are a little bit more certain. So after school programs like the summer treatment program that my friend Bill Pelham down the road at FIU have developed and disseminated across the country, those have strong effects too, as do some in-school based academic and social support. So obviously, if you're a school psychologist, you know that a lot of the treatments that we apply in schools have good support. And partly that's because the individuals that are in the best position to have an impact are close to the problem, and therefore they can have a greater impact. So generalization does occur there. And of course, even though as psychologists we do not prescribe medication, we're often involved in that decision-making process by virtue of providing assessment services and things of that nature. So I won't say a great deal about that, other than that the research supports it. Now, I will add a caveat, again, from my friend Dr. Pelham down the road, that the sequencing of treatments matter. So what he has found, and his team, is that it's important in many cases for the psychosocial treatments to precede the use of medication. The reasons for that aren't entirely clear, but it appears that part of the explanation might be that individuals that are receiving medication, the families that are going the medication route, may be less engaged or less inclined to kind of fully invest in the psychosocial treatments. And so even within the medical community, first-line treatments for ADHD really are behavior management training and some of the other things that I've mentioned, with medication as a support element. Right now, there are some exceptions where, for whatever reason, there are major barriers to some of the psychosocial treatments. Medication might be a better option in some of those circumstances. So I don't like to make any kind of blanket statements about what will work for any given family, but these are the things that we, at least that we know, have some beneficial impact. Of late, organizational skills training has gotten a lot more research support, especially for academic problems in the school. It's been a great help there. Homework support, I would include within that organizational skills training basket. And then as children get older, we need to adapt to the kinds of problems that they and their families have. And so communication and problem solving, another evidence-based intervention. So the bottom line is that we have a large menu of effective psychotherapy approaches, psychosocial approaches to choose from. So we're not in a desperate situation where we need to be reaching for unproven interventions, right? So here are some of the options that you have. Most of the innovation in stimulant treatments for ADHD over the years has really been in the delivery of the treatments, the delivery modules, and not so much in the types of medications that are used, which have been, pretty consistent. So there is some positive benefit there, but the word on the street is that psychosocial treatments allow you to get more sustained and bigger impacts on a wider variety of outcomes. So for those of you that have been following, ADHD treatment and treatment of, disruptive disorders, more generally, you might be surprised, right, that some of the biggest predictors of long-term problems are not the core symptoms of ADHD. And so the reason that's important is that you might not want to focus so much on whether or not a kid is acts like they're driven by a motor, or they're fidgeting in their seat. These are some of the high profile symptoms of ADHD, but those things tend not to connect in a meaningful way to long-term outcomes that we care about. As a result, you might, as a practitioner, and if you're a parent that has a child that has disruptive behavior problems, the kinds of things that you really do want to focus on that are important treatment targets are family and peer relationship problems, including sibling issues, academic failure, and of course, any type of involvement with the law. Those are the kinds of things that, as treatment targets go, these are significant things, and they're important to address. Unfortunately, they're not often being sampled in your assessment of ADHD. They're outside of the usual symptom profile for ADHD. In fact, if you look at what those three things, they are pretty strongly connected with conduct problems, right? So conduct disorder obviously gets a lot of clinical attention, as it should, because it represents kind of an endpoint in sort of failure to address lower level problem behaviors that occur in the context of ODD and ADHD. It's also the case that ADHD isn't universally viewed as a biological disorder. Some people have that view, but gene-environment relationships are complex, and just because medication is effective, it doesn't mean that that
the causes of ADHD lie solely in one's biology. Now, I'll stop short and say I am not in any way, shape, or form pointing the finger at parents when it comes to the onset of ADHD type symptoms. I think it's pretty clear that children bring a particular genetic, profile to the family, and that families, parents are not causing children to be hyperactive or inattentive, except in very extreme cases of neglect or abuse. So as a result, we can stop the blame game. We don't have to point the finger at parents. That said, we're not really in a position to change an individual's basic biology. And so one of the things I like to tell my students, some of whom are out there, good to see you guys, and that you guys will be familiar with, is that the child has not really chosen this. The parent's responsibility is to be response-able, not responsible. Responsible means that we're essentially pointing the finger of blame at them. But to be response-able means that you are there, you are present, you have skin in the game, right? You are invested, you are available to assist. And in that sense, of course, parents have an obligation to support their children, but it's not because it's their fault. In England, people have a very different view of ADHD. We use a lot more stimulant medication than the rest of the world. And in the UK, ADHD and other problems, disruptive behavior problems, are really, I think there's a better balance to some degree between the sort of environmental factors that contribute to behavior problems and the biological. And in our world, in the United States, stimulant medication is used far more commonly than psychosocial treatments, which, in terms of, if you want to view it in marketing terms, market share for psychosocial treatments for ADHD stinks. And as a result, a lot of people that might benefit from it are simply not getting it. So, as I said, these are the evidence-based, well-established therapies for ADHD. They include behavior management training, classroom behavior management, peer interventions, combinations of all those things, and organizational training. If you want more information about those things, you can go to effectivechildtherapy.org. I've got a little link to it, and they have extensive resources for professionals and for parents. And so in this day and age, I guess one of the messages that I want to share is that good, strong behavior management practices are good, strong behavior management practices, whatever the outside world conditions might be. And so if anything, it's even more important now to have your house in order with respect to behavior management than it ever has been before. And so it's not necessarily a matter from my perspective of doing things grossly different than one would ordinarily do them. It's more a matter of doing things more consistently and imposing some structure on what would otherwise be a very unstructured time at home for parents and children these days. So you might ask, well, what, these evidence-based treatments, how do we know they're evidence-based? What's the support for that? Well, as it turns out, a group of psychologists, of research psychologists, has established criteria for evaluating the evidence for different types of treatments. And this was led originally by APA Division 12, and then other divisions, including the Child Division, which is Division 53, followed. And the classification criteria are efficacious or probably efficacious. Those are the designations that you want. And in order to get that type of designation, you have to have a manual of some sort
and it doesn't mean that the therapy has to be rigid or linear. It just means that you have to be able to spell out what it is that a practitioner is supposed to do and that a client can expect in order to, to qualify. It also has to be subjected to randomized control trials, which is a particularly strenuous form of research evaluation. And we also have to have use of these interventions. Now, that's not part of the criteria for establishing whether something is efficacious or probably efficacious. This is more of a comment that, if you have an efficacious treatment but nobody uses it, it really doesn't matter. So our interventions not only have to be effective, they also have to be acceptable. And that's something that in recent years, people have paid a lot more attention to. In our clinic here at Nova Southeastern University at the ADHD, at our program, we have really strived to evaluate the evidence for our own effectiveness on an individual basis, right? So we track outcomes, parents' perceptions of treatment efficacy. Those are things that we try to do routinely so that we can be accountable. And hopefully, if you're a practitioner, you're doing that routinely. If you are a parent, you should be expecting that. You should be expecting people to be accountable and show you that the intervention is accomplishing what they say it does. There are also evidence-based interventions for other kinds of problems, including anxiety and depression. Those interventions are less dependent on parent involvement. However, parent involvement has gotten a lot more research interest and support in recent years. When it comes to anxiety, there's been a lot of attention paid to something called parental accommodation, which essentially involves parents intervening in ways that prevent their children from experiencing exposure and, we hope, reduction in their anxiety. So a parent's effort to try to protect their child is actually counterproductive, right? There's a little less evidence, I think, for parental involvement in the treatment of depression, except insofar as parents may model coping strategies that are not helpful, and certainly parents may begin to intervene or attempt to intervene in ways that are not helpful. So, for example, by punishing a child for sulking or things of that nature. So individual CBT, cognitive behavior therapy for depression, is a more commonly used intervention for childhood depression. And there's an intervention called behavioral activation, which is a little bit simpler, a little less complex, which also has increasingly good data and showing that you can't necessarily resolve or prevent depression, but the key is to sort of reduce the length of the bouts of depression. So again, we have evidence to support a range of possible solutions to child behavior problems and family issues, but we're counting on practitioners to utilize those things. And of course, in terms of marketing, Division 53 and psychology in general has to do a better job of marketing efficacious treatments to the public, much in the way that big pharma markets their treatments to the public. And unfortunately, we have no unified, coordinated approach to doing that. And that's something that probably needs to change. So, I've kind of spent the past few minutes arguing for the benefits of manualized treatments, and there are many. And broadly speaking, we have an array of efficacious interventions. However, there are critics, and I would count myself among those critics. And one of the areas where we can perhaps be critical of ourselves and what we're offering the public is that, you know, if you offer someone a full manualized treatment and you feel compelled to administer all 12 components of the manual, it's quite possible that some of the things that you're doing with that family are unnecessary. They may have already mastered those skills. Those skills that you're attempting to teach may or may not be relevant. I would compare it to going to a mechanic and telling them that you hear a knock in the right side of the vehicle, and the mechanic coming back and offering you an oil change, a brake job, an AC flush, and transmission flush. And you might say, well, all those are terrific things to do, but I'm really concerned about the knock that I hear on the right rear side of the car, right? So you might solve the person's problem, but you're giving them a lot of extra elements that make it, frankly, not as appealing to utilize your service. And so one of the things that I think that we need to do on the practitioner side is we need to be more careful about offering a manualized treatment where the full manualized treatment is not necessary. And that really requires an assessment approach that is problem-oriented rather than diagnostically oriented, right? So we'll come back to that. Another problem with evidence-based treatments that are manualized is, in order to treat the typical range of problems that one encounters in therapy, one might have to master a very large number of manualized treatments, and it might become unwieldy. It becomes even more problematic when you're trying to do that with individuals who are perhaps into their career significantly and may not be open to learning or being exposed to new treatments. It may also be challenging for people who are starting out in the profession, who might be overwhelmed by the demands of learning 6 or 7 different evidence-based protocols. And I won't even go into the fact that some of the providers of these kinds of treatments, for just PCIT as one example, it's a terrific evidence-based intervention for child behavior problems, but to be certified and to learn the approach may require a practitioner to take a week off to go to a city other than the city that they live in order to master the skills that are involved in behavior management training as it is described in PCIT. Is that necessary? Or certainly to administer PCIT, practitioners and developers of PCIT would tell you that that was so. But the real question is, can you get similar effects or even better effects with other approaches that are less intensive in terms of training? These are big questions and research questions in our field. And we're struggling with them because we know that dissemination and treatment acceptability are really important issues, right? And so is treatment fidelity, by the way. So I'm not arguing against developers that are very interested and very concerned about the manner in which people are administering the treatments that they develop. But I am asking, to what extent is it necessary for people to have high fidelity, right? So that's an empirical question. The last thing is more of a foundational type of issue, and that is that when we treat individuals in a diagnostic manner, we're really treating based on the topography, right? On what what the problems look like superficially. So we group problems by whether the child is aggressive or whether the child is withdrawn, without really looking at the function of their behaviors. And so I want to talk a little bit about what a functional problem-focused approach might look like. And I also want to be mindful of time because we've been at this a half an hour and I do want to have time for questions. So when should we deviate from this diagnostically driven model and perhaps consider a functional approach? And my short answer to that is when it's not working, right? And so it may be the case that for 60 or 70% of the individuals that are receiving conventional treatments for conduct problems, that we get a perfectly good result and impressive response to treatment with a manualized approach or a combination of manualized approaches. Some people advocate a modular approach to treatment, but it's still diagnostically driven and driven by topography. A functional approach is based on something else. So here's an example of a behavior, right? A symptom in the language of the DSM. Arguing, right? That would be a symptom of oppositional defiant disorder. And a functional approach would ask not so much whether or not the individual is doing it and how intensely, although we would certainly be concerned about that. It would ask essentially, what is the purpose of the arguing? What is the value of it for the individual? And if you want to get more sophisticated, we might even also ask, how is the parent's behavior functional, right? What is the parent doing and what is maintaining or supporting it? So if we think about the function or the purpose, if you want to use a more easily accessible term, if we think about the purpose of that behavior, what might we come up with? And within the behavior analysis realm, which is where this approach derives from, we have essentially four functions that we focus on. And the first one is parental attention, right? So in the case of arguing at home and a child arguing with their parent, perhaps the problem is really boils down to the child achieving or obtaining a great deal of attention from the parent for arguing. Another possibility is that the child may argue in an effort to gain access to an activity or a tangible reward, right? So for example, a parent may have an argument with a teenager about going to the prom, right? And the child may present arguments and talk about how other children are able to go and they're not, and the parent's not fair. And eventually that argument may be successful, right? Child may also argue to avoid punishment or avoid going to an activity. And that's where it gets kind of interesting, because in that scenario, you could have a child who was disruptive, whose behavior was considered disruptive. And by that, I mean, it could fall under the criteria of ODD or ADHD, or you could have a child who engaged in argument to escape having to go to school or having to go to a social event, in which case, diagnostically speaking, they might look more anxious or possibly withdrawn or depressed. So what's kind of interesting about a functional approach is it's not bound by the diagnosis. It's completely driven by the problem. And then the last element is that they gain access to something pleasurable. So in essence, some things we do, we just do because they feel good or because they terminate pain. And so substance abuse and things of that nature fall into that category, right? Things that, contrary to what Nancy Reagan said, drugs, were not bad, right? Many of the drugs that were abused were good in the sense that, not good in the broad sense, but good in the sense that they made the people that were taking them feel good, right? And it's also the case that individuals may vary in their sensitivity to drugs and just how good certain types of drugs make them feel. So this functional approach is extremely flexible, right? And it's driven by problems, not by diagnosis. So a way to remember this is everybody eats, escape, attention, tangible, or sensory functions, right? If you don't know a lot about this and you want to learn more about it, this is a terrific book called Functional Assessment and Program Development for Problem Behavior that was developed by O'Neill and colleagues. And especially if you work in schools, if you're a school psychologist, you may be familiar with the functional behavioral assessment that's mandated as part of the IDEA legislation. But even if you're not working in that context, this framework can be useful. So here's an example of an ABC analysis. For example, a teacher may ask for quiet. John burps, children laugh. Children laugh. John bows and smiles. The teacher asked him to move his card. The teacher asks him to move his card. John sits down, but he refuses to move. The teacher says, go to the office. And John gets up and he walks to the office, right? So in this little example, we've kind of broken down a moment in time. We've taken a little film, if you will, and we've cut it up to try to understand what's going on. And it begins with the teacher making a demand. John burps and people respond. So in the framework that we were talking about before, it sounds like child peer attention may be a factor that supports John's problematic behavior, right? Burping in class. John bows and he smiles. The teacher asked him to move his card. So they've got a token economy system in the classroom. John refuses to respond, right? He doesn't stop doing, he sits down, but he refuses to move his card. Again, this may be an effort to get some teacher attention and perhaps some additional response from other children. And then the teacher has just had it and says, get out of here, right? So now John's also got escape. So he's got peer attention, teacher attention, and now escape from the classroom. If we further analyze the antecedents and setting events, which are more remote elements, we might find that John is also not a very skilled student. And if, let's say this was a math class, this might be a class where he felt particularly inept. And so being kicked out of this class or removed from it, far from being a form of punishment, is actually highly rewarding to this child and may indeed serve to maintain their problem behavior. Now, this analysis has zero to do with anything that's going on in the DSM, and frankly has not much to do with much of what we teach in our manualized treatments, right? So I believe that this adds an element of sophistication for those who have learned manualized treatments only. I feel like this gives you a position to fall back, a way to understand behavior that goes beyond a manual, right? Because a manual will tell you simply how to react, but it doesn't tell you how to prevent or how to be proactive. A model, such as the model that I'm suggesting people think about, this functional approach, allows you to understand problem behavior in a much more sophisticated manner. I feel it's a nice complement to evidence-based interventions that are not functionally based or problem driven. And then here's a nice little tool. I won't go into it greatly because I want to get into our COVID specific material. But if you want to learn, this is actually from O'Neill, and if you want to learn how to evaluate and analyze problem behavior, this is a terrific way to organize that information. So if anybody wants to, Carlos, if you'll provide my email, and anybody wants some follow-up resources there, I'm happy to share them. So how does all this apply now, right? And my earlier words are the ones that I want to amplify, which is good behavior management is good behavior management, but there are some unique ways in which these problems manifest themselves now. And there's a nice resource here from NYU, and I hope that Carlos will be sharing our PowerPoint here. This is from a friend of mine by the name of Richard Gallagher, who's at Langone at NYU. And their team put together some really, I think, a nice guideline, a blueprint for parents in the home. And the things that they focused on really, I thought were two things. Number one, routines, and that was the vast majority of it. The second was children that are experiencing anxiety and mental health issues as a function of the pandemic. The routines are things like education, which are obviously right at the top of everybody's mind right now, exercise, sleep, and of course, how do you create opportunities for socialization and fun. I happen to have two children. I can't tell you how beneficial that is in this time, because the two of them are able to serve as an audience for each other. And while sometimes it goes awry, and there have been, I must confess, some bad moments between them, by and large, the good moments vastly outweigh the negative ones. They are support, entertainment for one another. And when mom and dad occasionally are losing it and maybe are a little extreme in their response, if they yell, they actually, believe it or not, defend one another, which is very sweet. So, so having a family unit in this time of crisis is a tremendous resource. But I realize, and I'm sure you all do as well, that not everybody has that, right? So one thing that we can do for each other is reach out to those people that we know are isolated and try to provide them with some support. And I would classify them among the individuals that we might consider to be especially vulnerable, right? So education, exercise, sleep, all of these things can be scheduled. And I believe that they should be. Especially in this time. If you are a therapist, one of the things that I would have on my to-do list is to make sure that every family that you're working with has a plan for the day. That includes as many of these elements as you can possibly squeeze in. Of course, even if you are practicing these routines with high fidelity, there are going to be individuals who are vulnerable and who will require care. Now, in our clinic here at the university, we've recently began to onboard the ability to do telehealth. Many other places are already doing that. And we can't forget that not everybody's going to respond to this crisis in the same way. And despite our best efforts at implementing effective behavior management practices, we may not always succeed. And by succeed, I mean we may not be able to prevent children from responding negatively despite our efforts to prevent that. And so we need to be aware of that. The simplest way to describe, and again, I don't know who exactly I'm speaking to, but whether you're a psychologist or whether you're a lay person, a parent, the number one biggest thing to focus on for an individual who's struggling is a change in behavior, right? So anything that's represents a marked change from their previous functioning is something that you should be paying attention to in a time of crisis. It doesn't necessarily mean that there's anything going on. You may investigate and find that there is very little reason for concern, or that the concerns are easily addressed. But they are concerns, and they need to be recognized. Don't be afraid that you're going to somehow disturb a sleeping dog. You need to go there, right? No matter how terrible you might imagine the consequences of doing so, you have to ask. If your child is deeply disturbed and having thoughts of suicide, God forbid, if that's the case, you need to go there. You need to dig in. If you're not able to do it, you need to find somebody like a professional who can. So it's always better to ask. So those resources from NYU are terrific. And these resources from Professor Matt Sanders, a good friend of mine from Australia, and his Triple P parenting program are really excellent. And, I would open them up, here, and I actually will show you a sample poster from this. but these are really great resources. And if you don't mind an Australian accent, they're even better. But here's a sample poster that really summarizes a lot of what they are recommending, right? And what I really love about this is how simple it is and how clear it is. And hopefully, I wish I could be as clear as they are in this poster. So number one, how do you cope with this pandemic? Reassure your children that your family is your top priority, that you are on the job, right? Number two, you guys are probably familiar, those of you that are therapists and have worked with me in the past, you know that taking your, if you're on an airplane and there's a crisis, they tell the adult to put the mask on first, right? And then once you get yourself situated, then you put the mask on the child, right? So that you can be there to support them. So this is the same kind of thing. Take care of yourself. Find a distraction. And there are lots of potential distractions. Don't feel guilty about that. Everybody needs a mental health, maybe not a whole day, because you may not be able to spare that, but you need a mental health moment, right? And so whether that's Sudoku or if you happen to have a boat that you like to tinker with, as I do, those are great distractions, right? But don't let them take over, right? Remember, number one is equally, if not more important than number two, right? So make your family a priority, but also make sure that you take care of yourself. Number three.
To show your, David, you want to reshare your screen?
Oh, okay. I'm sorry. I did not realize I need to reshare. Okay. So new share. Okay. Thank you for that. Okay. Are we better now?
Yes. Perfect.
Okay. See, this is a brave new world out here. So reassure your children, take care of yourself. And then number three, make sure your children know that you're ready to talk. A lot of us, don't want to hear that our children are scared, and we may be tempted to dismiss their fears or undercut them. It's really important to listen to them and to take their concerns seriously. Let them be heard, and also let them know that it's okay to be worried, but also let them know that, again, number one, you're there and you're going to do your very best to take care of them. And being truthful, right? That, you can take care of them, you can shield them, and they may say, my children say it to me, but Daddy, you're going to the grocery store. And I say, yeah, I'm going to the grocery store, but I'm wearing 2 masks. I'm washing my hands when I come home. I tell them about all the things that I'm doing. I go early in the morning, so I think there are fewer people likely to be there. I go to a grocery store that's larger as opposed to the smaller one that's closer because there's less density. I do everything that I can to keep myself and by extension my family safe. So that's the way I handle those types of questions, right? We try to maintain everyday, family routines, and we've even added a few. So the movie night with popcorn and ice cream is more important now than probably ever. Having a plan of action, right? And as situations change, travel restrictions, school closures, all of us right now, especially here in South Florida, are struggling with moment-to-moment changes in how the schools are going to operate. And some of us have to make hard decisions, including whether or not we're going to send our children to school or whether we're going to keep them home until the pandemic kind of wanes a little bit around here. Unfortunately, many of us have to make a choice right now about things that are happening in the future. And that represents a real challenge. And we've tried to be real open with our children about what we think is the best thing to do, but we're also listening to them about what they want to do and what they're comfortable with. Having interesting things to do at home. And this is one of the things that, if you are more affluent, you have more access to interesting things to do that are safe. One of the real tragedies of this pandemic is that individuals that have fewer resources tend to be living in closer quarters. That it's effectively less safe to be living your everyday life. And I think also it's less likely that you will have a wide variety of interesting things to do, at least insofar as they are attached to material things. But you can be inventive and creative about interesting things to do. And so that may be more of a crisis of imagination than of resources, right? Of course, one of the primary tenets of good behavior management, catching children being good, there's a lot of good behavior going on. In the midst of all the stresses that we are experiencing, it's very easy to overlook those things. So make sure that you pay attention to what your children are doing well, because undoubtedly they're doing a lot of things really well. And we can't allow ourselves to miss that because we're preoccupied with what's happening on Fox or CNN or any other news outlet that we might be concerned about. Helping children to learn to tolerate uncertainty, that's coming with the territory, isn't it? Right? We're all in the same boat together. And then, of course, we all have family and loved ones that we haven't seen or connected with. But there are so many ways, thank goodness for the technology that we have and the technology that I'm able to come to you with today. We can still connect with the people that we care about, and it's more important now to do that than ever. So, and that really does kind of tend to reinforce a sense of normalcy, right? So let me try to go back to my presentation here, and okay. And I asked Carlos to share with you a book that was written by a good friend of mine, Dr. Daniela Owen, out there in San Francisco. It's also a coloring book, and it's just a terrific resource that kind of covers a lot of the things that I've touched on today about routines and how to handle questions that children might put forward, and generally how to parent through a pandemic. I recommend the resources that Dr. Sanders of Triple P fame developed. Those are excellent resources, and the video that they have and the podcasts, all of those are really nice resources. You can pick and choose from those what you find useful. So I'm going to stop there. That leaves us to just about 10 minutes or maybe a hair less. Carlos, I can't see the chat. I don't know if you've been curating, but I'm happy to answer any questions that are there. I see there's a lot of comments. I'm probably not going to get to them all. Okay.
Great. Well, go ahead and you can unshare your screen for now, and you'll be able to see a little bit more.
I can unshare I stopped the share?
Yep.
All right. I stopped the share.
I'll tell you quite a few comments and a couple questions. Let me just throw one at you right away.
Okay.
You can certainly jump in. What are your thoughts on using CBD oil versus psychotropic medications for students presenting ADHD characteristics or related behavior struggles?
All right. I'm going to try to be diplomatic on this point. Show me the evidence. Unfortunately, to be fair to adherents and proponents of CBD oils, the U.S. government has not historically been interested in funding research on the benefits or possible negative side effects of CBD oil. So, unfortunately, you are, I believe, if you're recommending that or you are doing it yourselves, you are effectively, you've turned yourself into a kind of a human guinea pig. And, without any real guarantee of safety or really effectively controls on the product. As far as I know, they're not regulated by any particular agency, FDA, I know of no evidence supporting their use as a treatment for ADHD. That's for sure. And that doesn't mean that there couldn't be benefits, but they are not studied at this point. And, frankly,
I'm always open to, to convincing evidence that something's beneficial. It's not like we've solved the problem, right? So I would be open to evidence, but I don't know of any. Okay.
What would you say for parents with poor emotional coping skills that have fairly demanding children? The main parent team does not display self-control well.
If the problems are persistent and you are experiencing something more than a transient impact on your relationship, I would get professional help. There are a lot of therapists out there now that are able to reach you not only face-to-face, but also via telehealth. Healthcare providers, Medicaid, Medicare are paying for telehealth services, so it shouldn't be that difficult to access it. There are some restrictions on who can treat you. In other words, somebody in California, generally speaking, is not able to treat somebody who's located in Missouri. But assuming that provider is in the same state that you are, there are few restrictions on their ability to help you. So I think you should be able to find assistance. And of course, if you do find a practitioner, I would be asking them whether they practice in an evidence-based way and to show you or convince you that there is evidence supporting what they do.
Tons of questions are coming in, and as we're losing people as the 1 o'clock hour approaches, I will send out materials to everyone, additional the activity book and Dr. Reitman's PowerPoint presentation. 2-3 more questions, you think?
Sure.
Okay. Some interesting questions are coming in. We wish we could handle them all.
Yeah.
Is it healthy for these children to allow them to argue and sometimes win the argument so they could feel a sense of control?
Well, I mean, it's fairly broad, but, I'll sort of answer this a little bit from a personal perspective, because my children are 10 and 12, and occasionally they present some pretty compelling arguments, and I have to confess that I'm impressed with their resolve, even if sometimes the thrust of their argument makes me angry. So, I think you can lose the battle and still win the war, right? So the war is to end up with a child who is a good, decent human being that cares about other people and, is, reasonably productive. I don't think losing an argument is going to severely damage that. And in fact, as the questioner suggests, it may make them feel a little bit better about, things and allow them a sense of control. So I don't feel that you have to control everything. Resist that urge.
Is ADHD hereditary?
What's that?
Is ADHD hereditary?
If you're asking, is there a contribution from genes to whether or not somebody expresses ADHD? The answer to that is almost certainly yes. So the simple answer is yes, but there's a lot of nuance to it. So does it mean that if, say, a parent has ADHD that their child will? Not necessarily, right? Is there a greater likelihood that their child will if they do or if their husband does? Yes, there is. There could be the reason for that could be complex and not solely due to genetics, right? But yes, there is a higher likelihood, and this is not just with ADHD. This is with a lot of mental health and, of course, physical health problems, right? That's why when you go to the doctor, they say, "Do you have a family history of heart disease?" Well, guess what? If you have a family history of heart disease, you yourself may be more likely to express that kind of problem. So, So the answer is yes, but nuanced.
We've got tons of questions. We'll probably close our recording out and turn off Facebook Live in a few minutes. Over 30 questions still remaining. Best way to advocate for a child that school suspects having ADHD?
Number one, I'd say familiarize yourself with what the school's
documentation rules are for establishing ADHD. Basically, every school board is required to publish guidelines for how children get accommodations, what the rules are for receiving accommodations, what your rights are with respect to being evaluated at the school, what your rights are if you want to bring an outside evaluation in, follow their rules. Right? As long as you familiarize yourself with their rules and you follow their rules, you maximize the ability, your ability to get what you want. Right? If you don't know how to do that or you're not confident, you can always go to a professional who's competent and knows how to do that. Right? But most of us that are child psychologists have worked with schools. We're familiar with what the rules are, and we can help you with that. But you can also learn it yourself.
Any parting thoughts? Final
parting thoughts.
Yes.
Well,
final words.
I'm happy to, if you want to, those people that ask questions that want to have them answered, if you want to share my email, I'm happy to address them via email. I don't know how we can export the chat or anything like that. So you might have to restate your question in the email, but I do want people to feel like, like I'm answering their question, or at least I'm trying to. Parting thoughts are, it's a tough time. We have to be extremely flexible, but good behavior management practices are good behavior management practices. They're more important now than ever. If you need help, reach out to your local community mental health center or get in touch with your insurance company to get a referral to somebody that practices evidence-based treatments for child behavior problems. That would be my advice. Oh, and go to use some of the resources that I've shared and go to effectivechildtherapy.org, especially those of you that are asking about, treatments that are not established. There are a lot of people out there selling snake oil. I encourage you to stay away from it and use evidence-based treatments. If those don't work, the snake oil will still be there, right? But don't bypass an effective treatment for something that is unproven, because the failure to you're wasting time and resources on something that you really want to be careful about wasting resources on. Your children are too important to experiment with.
I did attend one of those snake oil events. It was quite disturbing, and I would be concerned that some could damage the children.
Yeah, and sometimes it's not damage by kind of being overtly harmful. Some of them are actually quite benign, right? What's not benign is that when I always use the example of Steve Jobs, right? Steve Jobs didn't want to get conventional treatment for his cancer, so he chose homeopathic methods that were not effective. They didn't kill him, but the fact that he didn't get effective treatment did. So, that's the comparison, or the analogy I would use.
Well, thank you so much, Dr. Reitman. Very informative. Obviously, you know your subject matter very well. We've had a number of people asking about certificates. For these events, we do not offer certificates. You will get a thank you for responding, for attending. We will be sending out the PowerPoint to everyone that registered. And just to remind everyone, we're Nova Southeastern University. We're in Davie, Fort Lauderdale, Florida is our main campus. We offer in the College of Psychology, bachelor's, master's, specialist, doctoral programs. We also have our clinics and great hat.
All right.
Very nice. Very good looking hat. We're proud to be the Sharks. We also do quite a bit of research. Dr. Reitman, did you create the Project Rise?
Yes, Project Rise has been working with the Miami-Dade County Children's Trust for 15 years, and we do consultation with them regarding their after-school programs, and we provide training to their staff and research consultation and a whole host of services. So we're proud to do that for the people of Miami-Dade County.
I always see creative materials, toys, and some different things going out for the kids. That's quite nice.
Cool.
In case you want to share this, we are at www.nova.edu/sharpchats. If you need additional information, our email is psychology@nova.edu, and we'll put you on our list. We've got a number of events coming up. In 2 weeks, we've got for the caregiver with autism, and next week we've got another social justice webinar. Most of these events, we've got hundreds and sometimes thousands attending, and they are a service to the community. Thank you, Dr. Reitman.
And before Carlos, I also flubbed the name of my clinic. so probably say the ADHD Assessment, Consultation, and Treatment Program is one of the service programs. We have many, many different clinics for child anxiety problems, for adult depression, you name it, we've got it at the Psychological Services Center at the College of Psychology at NSU. So we function a lot like a mental health center, community mental health center, and we're here for all of you that are in the Broward County area. So don't forget about us. If you need help, we're here for you.
Thank you, Dr. Reitman.